Well, first of all, I want to thank Kathy for facilitating this, and I also want to welcome and thank everyone for your interest in atrial fibrillation. I am a clinical cardiac electrophysiologist. I have been with Baylor for about 17 years when this first hospital was built, and I'm very excited to see all this progress, especially the expansion of the building. And I'm very, very honored and privileged today to introduce my two very, very dear partners, Dr. Javier Banchs. He's the director of electrophysiology in the Central Texas area. And during his tenure, he is instrumental in keeping us up to speed with all the new technologies, including subcutaneous ICD, leadless pacemaker, Watchman devices, and now a PFA post-field ablation procedure. And Dr. Banchs, outside of clinical area, his other professional interest is his passion in using artificial intelligence in educating patients regarding atrial fibrillation. And we're very, very happy for him to be able to join us today and share his knowledge of atrial fibrillation. My other very, very dear partner is Ms. Audrey Nicholson, and she, after a very, very successful career in the U.S. Navy as a lieutenant commander, we were very fortunate to have us with us for the last 10 years. Audrey is very familiar with all facets of treatment of electrophysiology problems. We implicitly trust her, and she practically run the EP program in Austin here for Baylor Scott and White. And she is also part of the leadership team in allied health profession in the very prestigious Heart Rhythm Society. And her passion is helping Dr. Banchs with the AI part, which is very, very intricate. And I'm looking forward to see some of the results. So the format of this is that each one of us will give a very, very brief presentation. And the idea is just really for you guys to ask questions. So we're not going to delve in depth with a lot of things unless there's a question that comes up. And in that case, we'll be very, very happy to address it. So without further ado, I let Audrey start our presentation.
All right. Thank you, Dr. Cheung. So I'm going to give a quick brief overview about atrial fibrillation treatment and the importance of why you're here in this meeting and why we're having it. So in AFib is two sides of the same coin. You know, when we come to treatment, it's a lifestyle side and then the medicine side that involves medicines, procedures, all of that good stuff. So one of the things that we always like to emphasize that AFib is a chronic disease. While there's no cure for this disease, it does mean, and it does not mean that life is over once you have an AFib diagnosis. So with your provider and yourself and your family, treatment involves careful decisions with the goal of improving overall health by making positive lifestyle changes, and following treatment plans are all parts of the complete AFib management strategy. So AFib treatment not only involves medicines or procedures, but also lifestyle changes. Adopting healthy habits is a crucial part of AFib treatment. It is recommended that you do 210 minutes of moderate exercise per week. I know that sounds like a lot, but this handy little chart here is a good tool to use. So moderate exercise is anywhere, walking, maybe some gardening, walking upstairs anytime you have the opportunity. So do that for 30 minutes a day and you've reached your goal already. We also recommend that you avoid excessive alcohol. Try not to drink more than 1 drink per day to prevent AFib recurrences. Also, sleep apnea is a big driver of AFib and is also a risk factor for many other chronic diseases. It is important to get tested and to wear your CPAP if it's recommended. I have a lot of patients that get tested and they don't want to wear the CPAP. And I wish I would say, hey, give it a couple months. You might be surprised how well you start to feel after you wear it regularly. Also, if you're overweight, losing weight can significantly improve your AFib burden. A combination of diet and exercise is the best way to lose weight and the best way to achieve your weight loss goals. Also, make sure it's really important that you stay on top of other health issues like high blood pressure or diabetes. These all contribute to AFib and the AFib burden, and so controlling them will help to better control your AFib. Now, treating AFib not only helps to avoid ER visits and hospital stays, but also helps to prevent stroke and heart failure. Ultimately, though, the primary goal of AFib treatment is to enhance your quality of life, which allows you to live actively and without limitations. So we treat your AFib with two strategies, rate control and rhythm control. Most people use a combination of both strategies, but some patients may only be on rate control depending on their overall health status. Rate control involves slowing down the AFib heart rate with medicines like beta blockers or calcium channel blockers. Rapid heart rate for too long in AFib can lead to heart failure. So to prevent damage during AFib episodes, your heart rate should be around less than 110 beats per minute, and ideally around 80 to 90 beats per minute. Most people, regardless of their AFib status, are probably on a beta blocker or a calcium channel blocker. Now, rhythm control is a strategy that uses medicines or procedures to actually keep your heart in a normal rhythm. These medicines, called antiarrhythmics, work on the heart's electrical pathways to keep you normal. They include medications like flecainide or amiodarone, for example. Now, rhythm control also uses procedures such as a cardioversion or ablation to keep your heart in a normal rhythm. Cardioversion is a shock or a quick jolt of electricity to reset the heart's electrical system back to a normal rhythm. And ablation uses catheters or thin tubes with special tips that we insert into a vein in the leg and then send it up through the heart to the inside of the heart to abolish the abnormal electrical AFib pathways. Dr. Banchs is going to talk more about this here in a minute. So without further ado, Dr. Banchs.
Thank you, Audrey. Good afternoon, everybody. I'm going to share my screen here to go through. All right, very good. I hope everybody can see the slide. So a little bit more about atrial fibrillation. All right, so the goals for managing atrial fibrillation should be, once you have it, to slow down the rhythm, as Audrey was mentioning. We want to prevent what we call cardiomyopathy, tachycardia-induced cardiomyopathy. So that could be the primary strategy for managing atrial fibrillation, as Audrey mentioned, as long as that leads to symptomatic relief as well. The other strategy is symptomatic relief. Patients need to feel better. They want to feel better. Some patients being just with the rate control strategy, slowing down the heart, don't feel good enough. So we want to correct the rhythm, as Audrey was saying. Another important element is stroke prevention. Atrial fibrillation can lead to a stroke. So we need to take measures to prevent a stroke, and then prevent recurrence and monitoring once the atrial fibrillation has been controlled. So rhythm control strategies include, as Audrey was mentioning, catheter ablation, medication, antiarrhythmics, and risk factor modification. I put in small caps there, cardioversion. That is, sometimes people get confused. The cardioversion is just resetting the heart, is one of the strategies for rhythm control to go from atrial fibrillation to normal rhythm. But maintenance of normal rhythm is low after just a shock treatment. That's what we refer to, either catheter ablation or antiarrhythmic drugs. And talking about ablation, the antiarrhythmics are medicines you take to keep your normal rhythm, as Audrey mentioned. But the ablation is a procedure in which we try to modify the electrical system of the heart with different energy sources to prevent the AFib from happening altogether. And that came from a study that was done many years ago. I mean, we kind of look for a long time where the atrial fibrillation comes from. And this group in France did publish in an academic journal their findings that most of atrial fibrillation comes from an area of the heart called the pulmonary veins. So the veins that drain the blood from the lungs into the heart after the blood has received oxygen, for some reason, have very unstable electrical activity, and that can lead to atrial fibrillation. So that led to the development of the ablation for atrial fibrillation. For other arrhythmias, we knew for many years that we could burn and eliminate some tissue, kill tissue that can cause arrhythmias, but we didn't know what to do for AFib. So this group come up with the idea, like, if we eliminate electrical activity and muscle fibers on those veins, we may be able to correct AFib. And then the procedure was developed. What we do is we map those pulmonary veins, the veins that drain the blood from the lungs into the heart, find electrical activity that is usually abnormal, and then with a catheter, we can apply energy, either radiofrequency energy that basically burns the tissue, or freezing with a balloon that gets really cold and eliminates the vitality of those muscle fibers that are misfiring. And more recently, a new form of energy, which is basically applying an electrical field of very high amplitude for very little amount of time that doesn't cause temperature raises or drops like freezing or burning, but it actually decomposes the membrane of the muscle cells that are there to eliminate their electrical activity. That is called pulse field ablation. That has brought a whole new perspective of safety of the procedure, and we have been using it in Round Rock now for a good amount of time. So there is another procedure that we're also doing in the greater Austin area for Baylor Scott and White, which is the convergent procedure. Patients who have had very advanced atrial fibrillation for a very long time and have very sick atriums, which we don't anticipate they're going to be corrected by a simple ablation of antiarrhythmics, we can partner with a cardiac surgeon who puts a tool through their chest, to the patient's chest, to do some component of ablation, and then later we do a second procedure in which we do the other component of the ablation. So this is almost like a sandwich technique. You know, the surgeon goes in the outer surface of the heart to do ablation, and we go in the inner surface of the heart to do an ablation. The other benefit is that when the surgeon has access to the heart, they can put a clip on the left atrial appendage, which is the area where the clots form in patients with AFib, to try to eliminate the risk of a stroke and allow the patient to discontinue anticoagulation. So that takes us to the discussion on stroke prevention. So the atrial fibrillation can lead to a stroke because there is a segment on the heart called the left atrial appendage, in which normally clots can form in patients who have atrial fibrillation. And then the traditional way to eliminating this risk was to use anticoagulants like warfarin. More recently, we have Eliquis, Xarelto, Pradax, and Sabaysa, who don't require of frequent blood checks and are a little safer from the standpoint of bleeding. And for patients who have bleeding problems, you know, we have the devices that can be used to implant in the heart and eliminate the source of the clots for atrial fibrillation. Here in these pictures, there is a little bit of a diagram of the heart with that appendage feature there, and an ultrasound picture that shows a clot. So because most patients with atrial fibrillation, when they have clots that could lead to a stroke, form those clots in that segment, it was developed a gadget like the Watchman device, who is here to the left at the bottom, that can be placed as a sort of umbrella that blocks off that area to prevent the clot formation. More recently, we have been using the Amulet device, who has two elements and has a fabric that allows for much earlier discontinuation of anticoagulation and helps prevent strokes. These two devices are man-made, so early on after they get implanted, they need to be monitored to make sure that the appendage is well excluded, that clots don't form in its surface, and give some time for it to heal in place. And after that device has healed in place and the procedure is successful, then the patient can discontinue anticoagulation. So the other option is a surgical clip, which is normally reserved for patients who go through the convergent procedure or patients who are not good candidates for the Watchman or the Amulet device. I want to remind everybody these devices are reserved for patients who are having trouble with the blood thinners, because the standard of care is to still use blood thinners as the first line for stroke prevention and atrial fibrillation. So long-term monitoring is important after the patient has developed a strategy to control their AFib, because they want to make sure they are not going very fast at any point in time, or that they don't have developed recurrences. Whatever the process is that leads to atrial fibrillation, we don't know that we can completely arrest it or eliminate it. And the best way to try to slow the progression is, as Audrey was mentioning, one of the sides of the coin, which is trying to optimize lifestyle changes and modifying risk factors that could prevent the progression and recurrence of AFib. So I'm going to let Dr. Cheung have a little bit of a wrap up, and then hopefully we can move on to questions.
Thank you, Javier, for a very comprehensive view of treatment of atrial fibrillation. I'm going to attempt to share my screen, and if it doesn't work, then Audrey will help bail me out here. Okay, so we're talking about obviously atrial fibrillation today. So this is the mission of our EP program here, is to provide state-of-the-art EP treatment to reduce atrial fibrillation so that patients can live better, and to help our cardiologist colleagues when they need help, and also to nurture growth and professional fulfillment of the team members. And these are our values. I don't want to bore you with that. So so why what kind of treatments do we need for atrial fibrillation? So Audrey and Javier had talked about the most important points of reducing the risk of stroke, because during atrial fibrillation, the top chambers of the heart is not really contracting, it's not moving, it's kind of like perforating, and because of that, the blood flow is not great. When you have stagnant blood flow in the top chambers, especially when there's a pulse, sometimes blood clot can form, and then if that blood clot gets dislodged, it can travel with the bloodstream to an organs, causing organ damage, and if it lands in the brain, it can give a person stroke. So it is imperative that people who have atrial fibrillation be assessed for the risk of stroke. So the risk factors for strokes include, this is not exhaustive list, but people with high blood pressure, also people of the age of 65 and 75, people with a history of arterial disease, or people with congestive heart failure, or people with Fisher-Price strokes. Those are all little risk factors that will increase the overall risk of stroke. And generally, we put people with high risk of stroke on blood thinner as an alternative for people who don't who are not good candidates for blood thinner. Dr. Banchs has shown some slides on putting a device in the appendage to help seal up the pouch where blood clot usually forms, and that's for blood thinner. So out of the three pillars of treatment for AFib, one is in the reduction and prevention of stroke. The second one is also very important, is for rate control. Everybody should at least have the heart rate control during atrial fibrillation. The reason is because the heart is not designed to beat fast all the time. At some point, if someone has AFib and the heart rate is fast continuously, it'll wear out the heart muscle. It also increase pressure in the heart, causing congestive heart failure. So the second pillars of treatment for atrial fibrillation is rate control. Everybody's rate should be controlled to prevent atrial fibrillation. And then the third pillar of treatment for AFib is to improve quality of life. Now, not everybody is affected by atrial fibrillation equally. Some people are very symptomatic, some people are not. So for people who are rate control and the issue of stroke prevention is addressed, some people may not choose to undergo additional treatment to maintain sinus rhythm. For those who do, we call that a rhythm control strategy. So again, we want to make sure we want to reduce risk of stroke or control the heart rate. After that, rhythm control is elective. So as far as when do we offer rhythm control? When people are symptomatic with atrial fibrillation. So on the screen here, I took this from one of the well-known studies. It's called a Cabana trial, and it looks at what kind of treatment do you do to maintain people in normal sinus rhythm. And of course, there are two forms of therapy. One is to take antiarrhythmic drugs to try to stay in normal rhythm as much as possible. The other one will be to do an invasive procedure we call catheter ablation. What is not shown here is an arm where there is no treatment, and we know from previous studies that the drug therapy and catheter ablation therapy is superior to no treatment, so it's not included here. But you can tell that on the y-axis, this is the recurrence of atrial fibrillation, and then on the x-axis is over time. So over time, the drug therapy is effective, but as time goes on, there are less people are able to maintain sinus rhythm. And then on the people on the catheter ablation arm, more people are able to maintain normal rhythm at any point in time. The other thing to notice is that neither treatment is a cure. If there's a cure, you can imagine a line on top that stays flat at 100%. That means 100% of people after going certain treatment stay in normal rhythm for the rest of their life. I think technology is getting better and better and better. We're getting closer and closer to that line, but we have still a way to go. So understand that when you take a drug and then you have AFib, it doesn't mean that the drug doesn't work. It just means that the drug doesn't work 100%. By the same token, if someone has an ablation, they still have AFib. It doesn't mean ablation doesn't work. It just means that ablation doesn't work 100% of the time. So those are the two main stay of therapy for maintaining normal sinus rhythm. And if you look at people with congestive heart failure and atrial fibrillation, on the y-axis is mortality rate, and you can see that people with congestive heart failure, the rate of bad outcome is more with medical therapy, not because medicine is bad, it's just because it's not as good as ablation therapy. And then the outcome for the red line is patients with ablation, there's a lower event of death, for people who have congestive heart failure undergoing treatment for atrial fibrillation. So how do we treat with ablation procedure? Well, there are two-way. One is you freeze it, one is you burn it. There's a trial called Fire and Ice. It's published in the New England Journal of Medicine. On top here, you see that there's a balloon going into a vein. So if you remember some of the picture you saw in Audrey and Dr. Banchs' presentation, it showed a picture of where the atrial fibrillation occurred that is in the top chambers of the heart. And we know from clinical research and broad-based patient experience that by most of the atrial fibrillation initially emanate from the pulmonary vein, and by isolating the pulmonary vein, either with freezing, you put in this picture, you put a balloon and you infuse it with liquid nitrous oxide to freeze the vein. The idea is that you crystallize the cells, the tissue, and then the crystal will kill the cells, and then it will be over time replaced by scar tissue. At first there'll be inflammation, and eventually it will be replaced by scar tissue, and the scar tissue will not allow electricity to fire from the vein. So this is freezing, so that's the ice part. And then before freezing, we used to go for radiofrequency ablation, which is a point-by-point click, and high frequency currents to heat up the tissue, to burn the tissue. So the previous one, you kill the cells by crystallizing it. That this one, you actually use heat damage for that. I apologize if there was technical difficulty, and if you're not able to see that, I can show you the last one. On top here, we have a balloon infused with liquid nitrous oxide to freeze the vein. Bottom here, we have a catheter doing point burning of the tissue around the pulmonary vein. So part of the old problem with these approaches is that heat doesn't really clear whether you are the heart or whether you are the esophagus behind the heart, or your phrenic nerve next to your heart, or and it can also sometimes cause extensive scarring of the vein, which is one of the things we try to prevent during the procedures. So heat and cold energy, though, is very, very good, very, very effective. We have to use it very, very, very gingerly. With the new technology that we have that's been approved for the last year now, and we're very happy to acquire that at the Baylor Skyway system. Instead of heating, burning, or freezing, we basically just deliver an electrical field. Now you're going to ask, what does the electrical field do? So basically, if you look at the picture on the right-hand side, this is a cell. This is, when you have a group of cells, it's the tissue. We want to do ablation of diseased tissue. So we want to damage those cells intentionally. And when you apply an electrical field, you can see the positive and negative end of it, and the electrical field is going through a cell. Under the influence of this electrical field, the membrane is going to leak ions. When you leak ions, it can no longer maintain the integrity of the cells. So over time, the cells will die and it will be replaced by scar tissue without the physical trauma of heating and cooling the tissue. And it turns out that this energy is very, very tissue selective, and it's very, very sparing of all the innocent bystander that happens to be next to the heart itself. So because of that, it increases the safety profile. And also because of the effectiveness of this energy, the reconnection rate is lower. In the past, we understand that after initial success of isolating these veins, when you see no electricity communicating, over time, when the inflammation subsides, there is more healing, and sometimes you will have reconnections. And with this technology, there's less of that. And this is another view to see how this electrical field is delivered. Is usually between a positive and negative pole to generate electrical field on the catheter. This is another catheter. This one, again, is a three-dimensional depiction by artists of what the electrical field looks like. And then this is another configuration demonstrating this little globe. So, but of course, in real life, you're not going to see any glowing globe. It's just going to be an electrical field that's experienced by the veins. So that's basically the most exciting part about the treatment of atrial fibrillation. The bottom line is we have to fall on the foundation of controlling the blood clot, reducing blood clot, preventing stroke, controlling heart rate, And for people whose quality of life is affected, to offer them rhythm control strategy, whether it be with medications or with ablation catheter. And that's tremendous advance in the field of catheter ablation with this new technology. With that, I'm going to close, but then I'm not going to stop talking. I can talk about AFib all day, but it's time for the audience to ask questions, and we'll be happy to answer them.
We did get one question in the chat, and it was somebody who was asking, how do they know if they have atrial fibrillation? When should they be going to the doctor or the emergency room?
So we're gonna spread out. I'll start with Audrey, and then we'll just go around the panel, and then we'll give our answer.
All right, so how do you know if you have AFib? A quick and easy way, a lot of people these days have Apple Watches or Cardia Mobile. I don't have an example in front of me right now. And they're wearing their watch and it says, hey, you have AFib. Or maybe they have a Fitbit, a heart rate monitor, and they're noticing that their heart rates are constantly elevated. You know, you go to the doctor, that your primary care, and they run an EKG and say, yeah, you have AFib. So very common ways are on all the wearable devices that we have at our fingertips. Also, you might just be at a routine physical. So it's really important to keep up with routine doctor visits, because sometimes they'll notice an irregular heartbeat when they listen to you, or they'll notice that your heart rate is fast. Other ways we find out that people have AFib is maybe they go for a colonoscopy. They check in and anesthesia says, oh my goodness, you've been fasting for 3 days and now you're in AFib. So those are the pretty common ways. AFib is very common, you know, roughly anywhere from 30 to 50% of Americans will have it at some point in their lifetime. So if you do see one of these wearables that says you have AFib, don't panic, but definitely don't ignore it. Please follow up with your primary care at minimum.
Yes, well, I could say that also, you know, regarding the going to the emergency room, you know, I could say patients with atrial fibrillation should go to the emergency room for feeling however they would otherwise make them go to the emergency room, meaning that if they have an emergency that is not related to the atrial fibrillation, but it could be caused by it, like passing out, having ongoing chest pain, they cannot breathe, they feel like the difficulty breathing is worsening. If they don't feel safe at home, they should go to the emergency room. But otherwise, having AFib by itself doesn't necessarily prompt an emergency room visit unless you need to get on a blood thinner, for example, right away, or medication right away because you haven't been on it. But atrial fibrillation most of the time could be managed as an outpatient as long as the patient is not having severe symptoms. So any severe symptom, if you think about it, it doesn't matter that you are having AFib or not. If you have a symptom that is very severe and you don't feel safe at home, you should still seek care emergently. So that could be a reason to go to the emergency room if the symptoms are severe and you don't feel safe. As Audrey mentioned, some patients get symptoms that they don't know what it is and they go checked and find AFib. A lot of people nowadays find atrial fibrillation just by monitoring at home. And of course, if you're not sure, but the Apple Watch told you you have it, well, you go to your doctor and they get an EKG or they give you a longer monitor with a better quality of tracings that could confirm the diagnosis.
I'm going to break the questions into 3 parts. You know, how do you know you have atrial fibrillation? I would say, you know, the first part will be how do you diagnose AFib. The second part will be how do you know you have AFib? And then the third part will be how do you experience atrial fibrillation? Yeah, what's up? So for how do you diagnose AFib, obviously, you probably shouldn't diagnose yourself with atrial fibrillation. Apple Watch will try to be helpful, but at the end of the day, you know you have AFib when the doctor evaluate you and tell you you have atrial fibrillation. But if you have an Apple Watch and they give you a hint, sometimes it's wrong, sometimes right. Most of the time it is right. And so it's usually you know, made by a health profession. As far as how do you discover the AFib, I would say, you know, depending on the severity of symptoms, some people have no symptom whatsoever and they come in very sick. They didn't know that they're very sick until they come very sick. Some people truly have no symptom and don't feel sick at all and they do it very well with atrial fibrillation. But for most part, people are symptomatic, and then on the other end of the spectrum, people are coming with congestive heart failure with atrial fibrillation. And I think most people will just be in between. The typical scenario where people will discover they have AFib is they may have some palpitation, but they are too short to catch, and that they're also too infrequent to catch. But as time goes on, because of the natural history of atrial fibrillation, it becomes more and more frequent until one day, you know, you can actually catch it from the emergency room visit on EKG. or sometimes you just say to go to see a doctor and say, hey, I've been having this palpitation and voila on the EKG, or sometimes you may not even see it and then you can catch it on a ambulatory monitor. But nowadays, with the advent of all the technologies, it's not now uncommon for people to, get themselves a smart watch device and to be able to diagnose this earlier. So that's how a lot of time people when have some symptoms, it takes a while for them to diagnose. And lastly, the last part is, as I stated in the beginning, everybody experiences atrial fibrillation differently. Some people are severely affected, other people are asymptomatic. But regardless whether they're symptomatic or not, we have to address the underlying health outcome, such as stroke, heart failure, and brain control.
Okay, so we have a good question. What is the risk of having an ablation? Dr. Banchs, do you want to start that?
Yes, well, the ablation is an invasive procedure, right? And we are getting into the left side of the heart, which is, where the clots could form and where the appendage is. And it is, it's continuously connected in the circulation with the brain. So there is about 1% risk of a stroke. It's usually a mini stroke if it happens during the ablation procedure. We need to put catheters inside the heart. We go through the low pressure system of the vasculature, the veins in the groin, but then the risk of bleeding or damage to the blood vessels is about 1 to 2%. The risk of perforation of the heart with the tools that we're using and causing bleeding around the heart sac and the need to put a drain and some pain is about 1 in 300. The risk of needing open heart surgery as an emergency is close to 1 in 500. And the risk of death is less than 1 in 1,000. So it's definitely some risk. But, to put it in perspective, I don't know that it's true and the statistics are such, but I tell patients, if you think about it, every time you get on I-35 here in Texas, you're taking a lot of risks. So I think that our procedure suite is way safer. And we definitely are good drivers when we are there. So there is always risk. But the risk of overall complication, I would say it is close to 5 to 6%, including all these things that I was mentioning. 95% of patients do well, from the safety perspective.
All right, thank you. Anything to add to that, Dr. Cheung?
No, but I just migrate over to Audrey because I was told that the audio is not very good at my computer, in case you're wondering. I think that I'm very, so AFib is my passion, and I'm very energized, by the progression. I have, dealt with atrial fibrillation, since my training in fellowship. I finished in 2004, and I watched progression of treatment of AFib with agonizing speed for the last, agonizingly slow speed for the last 15 years. And the ray of light came when we moved from radio frequency ablation, which is essentially heating the tissue for first, probably decade, to, cooling in the last, 5 years. And I think that the current technology is a quantum leap. It's still not a cure, but it really brings, me joy and really energizes us, because as physicians, we are here to stamp out AFib as much as we could, even though the reality is we are reducing atrial fibrillation to be more realistic and practical.
So there is a question about persistence of symptoms after having had an ablation for atrial fibrillation. So I think it's important to discuss a little bit the challenges of the ablation, the success rate, and the combination of therapies.
Yes. So it's not a cure, and as you can tell, if the graph showed up correctly, the benefit of a treatment is the area between two curves. So that means that we know from a population standpoint, taking a medicine increase the time lived in normal sinus rhythm. Doing ablation procedure increase the time lived in normal sinus rhythm. That's what we know. And as far as like recurrence, yes, when you take medication, you can have recurrence AFib. When you do ablation, you get recurrence atrial fibrillation. The only time it doesn't happen is when we have a cure, and we don't have that. It does not mean that everybody will have recurrence of AFib, because I think that, probably, I would say, and I'm very concerned, I would say probably 50% of people will truly have no AFib. But the question is, how long do you wait before you say that that person has a cure? Do you wait 2 years, or do you wait 1 year like the clinical study? Do you wait 2 years, or do you wait 5 years, or do you wait 10 years? a lot of time, I said, maybe more than half of people may have no AFib, but you never know that they'll never have AFib again. That's why the guideline recommend people on blood thinner to continue blood thinner. As for the rest of people with, I would say probably 30% will have recurrence of AFib, but I think it is in most providers' observations that their burden, that means the time they spend in atrial fibrillation, is decreased. Now, because atrial fibrillation is a progressive disease, there will be a time that AFib will come back and stay. I always joke with my patients that if they live to 200 years old, everybody will have AFib. And when you do some treatment, basically hopefully you reverse the disease somehow. But being that we are mortal being, that time continue to run on us, then theoretically AFib can always come back. So the idea is not curing AFib, that it never come back again. It does happen for some people, but I don't know who they are, because I don't know whether I should declare that at 20 years or not. But the idea is that the point is that in a population, people who undergo treatment will have less atrial fibrillation. Does that answer the question?
Yeah, thank you. Okay, so we have another question here. When exercising, is there a limitation on max heart rate after an ablation? Immediately after, it's probably not a good idea to do significant exercise for about a week, just to let the access site in your leg heal up. But as far as long-term exercise, there really isn't, without getting too much in the weeds, there isn't so much of a max heart rate that triggers AFib. In rare cases, AFib can be triggered by exercise, but that really has more to do with adrenaline and endorphin release that sometimes happens with exercise. Like I said, it's not common. And so we actually encourage people to exercise. And even if you're in AFib, as long as your heart rates aren't going too fast where they're making you lightheaded or have significant chest pain, you can even exercise while in AFib. So really there's very few limitations after an ablation for heart rates. Let's see, Dr. Banchs. So good question here. How long can you be off blood thinners before you have a stroke?
Yeah, that is a very complicated question and at the same time answer. So it is hard to predict, but we know that the risk of a stroke is proportional to additional risk factors for having a stroke that are unrelated to AFib. So if you have atrial fibrillation, you have a given risk of a stroke, but if you do have hypertension, diabetes, problems with your heart valves or with your heart muscle, or what we call heart failure, if you have had a stroke before, or if you have vascular disease, coronary artery disease, atherosclerosis in some of your arteries, or if you are older than 65 or 75, I mean, the risk of a stroke goes up exponentially with age. So, depending on how many of those risk factors where you are, your risk of a stroke is going to be higher being off the blood thinner. Now, we recommend not to discontinue the blood thinners. Overall, patients with atrial fibrillation that have certain risk profile that is calculated by different tools that should be on a blood thinner, and we recommend not to stop it. Of course, if you're going to have surgery, if you're going to have a colonoscopy and they anticipate they're going to remove a polyp, or if there is an anticipated higher risk of bleeding, or if you're already bleeding, you need to discontinue it. So the question is, what's the risk, right? I mean, that's exactly what the question is being asked. So we didn't have a clear-cut answer until one of the largest studies on patients with atrial fibrillation was completed, which was for the approval of Xarelto as an anticoagulant, as an alternative to warfarin. So when they did that study, those were about 20,000 patients that participated for a long time on that study. And they looked back to see what happened to the patients who needed to stop the blood thinners for whatever reason. So the conclusion was, and this was a relatively high risk of a stroke group because they had a strong indication to be on a blood thinner. They stopped the blood thinner between 3 and 30 days for different reasons: bleeding, surgery, and the risk of a stroke in that period was less than 1%. So this is not to encourage people to discontinue their blood thinner for longer periods of times, but this is to reassure that if you are having surgery and you need to stop the blood thinner, is not very risky. Of course, the risk is never going to be zero, but it's less than 1%. And now it's a standard of care to discontinue anticoagulation for brief periods of time, usually 48 hours or so for the newer drugs, if patients are going to have an intervention that could lead to bleeding. Keep in mind that if you have a bad bleeding event in one of those surgeries, or if you don't discontinue it and you end up having a lot of bleeding, you and your doctor are going to want to discontinue that blood thinner for even longer amount of time until they know for sure you're not going to bleed again. So not discontinuing and having bleeding complications is a very strong reason for a patient not to take it ever again. So discontinuation temporarily is a standard, and there are some rules of how to do it. We used to bridge people with stronger blood thinners around the time of the surgery, but that led to a lot of bleeding events, and that is a very uncommon practice nowadays. So it's a very complicated answer, but the risk is relatively low if it's done for a brief period of time and with a good reason.
All right, thank you. And someone else asked to talk about the Watchman, and you kind of already covered it, Dr. Banchs, but that leads to the point of, if for some reason you can't take a blood thinner because you have maybe a GI bleed or you fall a lot, then that is what the Watchman or the amulet, those are called left atrial appendage occlusion devices. That's where they're indicated. And right now in the studies, they're not they don't have better stroke prevention than the pills, than the oral blood thinners, but they're pretty close. And so for our patients that can't safely take a blood thinner but still have a stroke risk, that's when we recommend that they consider having one of those implanted. Okay, so we have someone who asked, what do you consider an elevated heart rate that needs to be treated, Dr. Cheung?
So
Age-old question.
it depends on the circumstance. So I, make an analogy of your car speed. What's a normal car speed? Of course, in the garage it's 0 miles per hour, and then on I-35 maybe it's 70, hopefully, and not 90. But it really depends on what you do. So when you're at rest, and you're checking your heart rate, you should always do it when you're at rest. It's hard to check your heart rate while you're exercising or working. And not only is it at rest, you should be, make sure that you're relatively calm. You're not watching anything exciting on TV that get your blood boiling, and that you're not having an argument. And I would say in a peace of mind, it should be less than 100 beats per minute. So when you take your pulse, you just want to take it for longer periods just to make sure that it is correct. When you're exercising, depending on your age, so young people can get the heart rate up very, very high. And as we get older, our heart rate tends to go down. But your heart rate at rest should not be consistently be over 100 beats per minute. Now sometimes in AFib will allow people to be 100 up to 110. This is called linear rate control. But normally you're not on that strategy. Your heart rate should not be over 100 beats per minute. Now some people will. There are some minority of people who have normal resting heart rate. And when they get up, the heart rate will become too fast. That's not very, very common, but we do see that from time to time. If that's the case, then I would say check with your doctor and get a monitor, and then you can assess and find a good range of rate control that is acceptable and comfortable for you.
Yeah, I think it's important to note time frame. A few minutes of a heart rate over 100 beats a minute is probably not significant, but if it's staying that fast for several days, and at that point you should definitely reach out, if not to your primary care, if you have a cardiologist, or to your EP. That's important, so that way we can get your rate controlled, so that we can avoid you developing heart failure or a low squeezing function. So someone asked, does ulcerative colitis put you at high risk for a stroke? As far as AFib goes, it's not a specific risk factor for AFib for stroke. When we talk about stroke risk for AFib, we use a scale called the CHADS-VAS score that involves if you have congestive heart failure, high blood pressure. If your age is 65, you get a point, and if you reach 75, you get an extra point. If you have diabetes, if you've ever had a stroke or a blood clot in your lungs, that you get 2 points for that. If you have peripheral vascular disease, so maybe you had some work on the veins and arteries in your leg, but then also significant cardiovascular disease, so if you have blockages in your arteries in your heart. And then your gender. Women get 1 point just for being lucky to be women. So I think I I got everything. So those are the factors that we use to gauge stroke risk when it comes to AFib specifically.
That's absolutely right. Although unfortunately, ulcerative colitis does carry a little bit higher risk of a stroke long term based on population studies. But there is no consensus that if you have AFib and ulcerative colitis, that is counted as a risk factor, as Audrey was saying. What the recommendation is that somebody who has ulcerative colitis, because of the higher risk of a stroke, should pay special attention at reduction of overall cardiovascular risk factors, which are the same risk factors for a stroke, which include high blood pressure, control the high blood pressure, and be very aggressive with the treatment of diabetes, be very aggressive with the treatment of hypercholesterolemia, and keep a healthy lifestyle. But there hasn't been an association between AFib and ulcerative colitis as one of those risk factors, as Audrey was mentioning.
One more question, Dr. Cheung.
Which question?
What % of Scott and White patients are having ablations in their 80s?
So I think people are very rich in background and health and activities. So we don't generally go by the age. Definitely, someone who's healthy and active was 80 years old. It doesn't stop us from offering the procedure. At the same time, if someone has 60 years old, has a lot of comorbidities, that will put them at a higher risk, for procedures. Generally, I think the overall picture is more important than one single factor, such as the age. Having said that, of course, as we get older, we tend to have more comorbidities. In my practice, I think that when we're doing radio frequency ablation procedure, my age limit was lower. Just because we think that having a technology that doesn't differentiate between target tissue and surrounding tissue may be a little bit higher risk and longer procedure. With the posterior ablation, because it's a much shorter procedure and also virtually little or none innocent bystander damage, I think the risk for the procedure is lower. So that age becomes higher. If I look at my ablation for the last year, I would say most of my patients are probably in their 70s. I think that maybe about I would say maybe 1/6 or less than 1/6 will be in their 80s. That's just not because of the age limitation, but it's just because of whether they are strong enough, to have the procedure.
Dr. Banchs? Any further comments?
No, I think we don't discriminate by age. We, of course, need to make an assessment of the risk of the procedure, individualized by the patient and their condition. But yeah, I estimate that maybe my percentage of patients older than 80 is a little higher than 1/6. But we have that a very personal discussion with the patient. We also tailor the procedure, how aggressive to be, if it is a complicated situation. And also the success rate, right? Depending on many risk factors and the size of the heart, how long has it been going, what other problems they have, the success may be estimated as being higher or lower. So that's a very personal discussion with the patient and their family to see what they are seeking. There are other treatments that we didn't talk about, like putting a pacemaker and doing an ablation of the connection between the top and bottom chambers of the heart. Sometimes we go to that as an alternative. We don't like to doing that one, so that's why we don't talk much about it, but that's still an option. So in a more personal situation, we'll figure what's best for the patient and how, the important thing is not to do any harm, but to make people feel better. So I think that goes all in the discussion.
But I think you both touched on it, but it's important to remember that with the newer technology that we have with the pulse field ablation, that it is expanding the age range a little bit, and maybe people who before we were a little hesitant to offer an ablation as a treatment option for. So that's, technology is always advancing, which is good. So I think with that, unless Dr. Cheung, you have anything else?
No, I want to thank my partners. I want to thank our administrators and Kathy for facilitating this. But most of all, I want to thank the audience for being engaged and interested and letting us have this opportunity to share our knowledge with you.
Thank you.